Good day, and welcome to this lesson on respiratory clinical pathophysiology. In the previous lesson, we looked at signs of compensation, which includes breathing faster, breathing deeper, and using accessory muscles. We also looked at signs of decompensation, which includes slowing or shallow breathing, reduced consciousness, and falling oxygen despite support. By the end of this lesson, you will be able to recognize compensation and decompensation, identify signs of impending respiratory failure that require escalation. Let's start by asking, how do common respiratory conditions differ clinically? Respiratory diseases often produce similar complaints, such as shortness of breath, cough, and fatigue. What differentiates them is the mechanism behind the symptom. Advanced clinical reasoning requires identifying whether the primary issue is airflow limitation, alveolar filling, chronic structural damage, or perfusion blockage. Asthma. Asthma is a reversible airflow limitation caused by bronchoconstriction and airway inflammation. In asthma, airways become narrowed, making it difficult to move air out, leading to uneven ventilation and low ventilation and perfusion. The patient commonly experiences episodic wheeze, chest tightness, shortness of breath. Their breath sound is an expiratory wheeze, and the patient usually experiences cough dry, often worse at night. The core problem in asthma is difficulty with ventilation caused by narrowed airways. COPD, also known as chronic obstructive pulmonary disease. COPD is a chronic and progressive airflow obstruction with air trapping. Over time, effective ventilation decreases, and carbon dioxide retention may develop. Common features of COPD include a chronic productive cough, progressive shortness of breath, and a history of long-term exposure, especially smoking. Breath sounds may reveal reduced air entry, wheezing, and prolonged expiration. The core problem is impaired airflow out of the lungs, which can eventually lead to ventilation failure. Pneumonia. Pneumonia is a gas exchange disorder where alveoli fill with fluid or inflammatory material, preventing effective oxygen transfer and causing low ventilation and perfusion. Pneumonia commonly presents with fever, productive cough, shortness of breath, and fatigue. Breath sounds may reveal crackles breathing and bronchial breathing. The core problem is that the alveoli become filled with fluid or infection, preventing oxygen from transferring effectively into the blood. Pulmonary embolism. Pulmonary embolism is a perfusion problem caused by blockage of pulmonary blood vessels. In this condition, air reaches alveoli, but blood does not, creating high ventilation ad perfusion. Pulmonary embolism often presents with sudden shortness of breath, pleuritic chest pain, and tachycardia. Breath sounds may appear normal. The core problem is failure of oxygen transfer caused by blocked blood flow in the lungs. In summary, we said asthma reversible airflow obstruction caused by airway inflammation and bronchoconstriction. Chronic obstructive pulmonary disease is a chronic progressive airflow obstruction with air trapping. Pneumonia is a gas exchange disorder where alveoli fill with fluid or inflammatory material. And pulmonary embolism is a perfusion problem caused by blockage of pulmonary blood vessels. That is all for this lesson on respiratory clinical pathophysiology. Thanks for watching. See you in the next lesson.